is Brenda. I'm ready to go, Becky. Okay. Welcome to our webinar today on Medicare rules and recent waivers around the delivery of diabetes self-managed education via telehealth. My name is Brenda Jagatic, and I am the Diabetes Education Coordinator at the Indiana State Department of Health. Becky, I'm hearing some feedback. Is this okay?
I'm getting a little feedback too, but everybody else, Marianne, could you go ahead and mute yourself?
I'm on a cordless phone.
Oh, okay.
I muted her.
Okay, thank you.
Okay, am I ready? Okay. So my name is Brenda Jagatic, and I am the Diabetes Education Coordinator at the Indiana State Department of Health under the CDC 1815 grant, and my role has been to increase diabetes education in the state of Indiana. This has included providing technical assistance to diabetes education programs around the delivery of services via telehealth in collaboration with both Marianne Hodorowitz, who is our speaker today, and Becky Saunders from the Upper Midwest Telehealth Resource Center. And it has been a pleasure since the beginning of this pandemic. We have been able to collaborate more intensely to provide technical assistance around these waivers. And now it is my pleasure to introduce our speaker, Marianne Hodorowitz, a respected certified diabetes care and education specialist, dietitian, national speaker who is wealth of information on the Medicare rules and reimbursements around the delivery of diabetes self-managed education, as well as via telehealth. Go ahead, Marianne.
Okay. So thank you, Autumn, for unmuting me. Becky and Brenda, can you hear me?
Yes.
Perfect. Well, hello, everyone. My name is Marianne Hodorowitz, and some of you know me. You've maybe heard me do other webinars and speak at the podium. I'm just really honored and thrilled to be with you today. Bright and sunny day here. I'm from a suburb of Chicago. I think it's like 60 degrees here. It's a miracle. And I'm in my dining room, and I'm just so pleased with all the organizers that made this happen. And I want to just give a big shout out to everyone here, because everybody did a lot of work to bring this webinar to you today. We have several learning objectives. We have 4 here. And for the sake of time, I'm not going to read through every one, but let's just say that this webinar, the purpose is to review all of the last-minute, up-to-date, very current Medicare waivers on the DSMT telehealth benefit for you all, so you can do this in your practice setting and be reimbursed with far less restrictions that the original rules gave us for doing in-person DSMT or diabetes self-management training. So when we call it training, that is the Medicare term that is used. The rest of the world calls it diabetes self-management education and support. So when you hear me say DSMT, we're specifically relating this content to Medicare. This disclaimer basically says that the information is as up to date as we can possibly get it at this point in time. And Medicare has been changing its own waiver rules literally every day. I've been on the webinars of the Academy of Nutrition and Dietetics about the COVID waivers for DSMT and MNT, and also their Q&A webinars. I've been on them with the the Association of Diabetes Care and Education Specialists, again, webinars and Q&A webinars, and they have also said that literally every day Medicare is changing the rules. So last night, this deck was submitted on Wednesday, and last night there was 2 small little changes that I became aware of, and I'll let you know that when we get to that point in the deck. And this deck is going to be available to all of you after the webinar. And what I'm also going to do is take your questions about every 15 minutes. This webinar is scheduled for 90 minutes, an hour and a half. So I will be very mindful of everyone's time. But to get you more, feeling more engaged, because this is virtual, isn't it funny, because we're talking about telehealth DSMT, and this is a virtual kind of presentation, although we don't have visual. So about every 15 minutes, I'm going to have the organizers, either Becky or Brenda or Autumn, read me your questions in the chat box. And that's where you would input your questions. simultaneously to me reviewing this information. Now, I don't read word for word from the slide. Some of you probably already know that. I'm going to highlight what I call the key core message. And so I'm not going to go rapidly. I'll go fairly slowly because I know this is really confusing. And again, this has been trying to nail Jell-O to the wall because everything is changing literally every day. But this one I do read word for word because I just think it's so comical and it kind of sets the stage here. The golden rule. He who has the gold makes the rules. We're talking about insurance companies. The gold, of course, is the money. He who wants the gold must identify all the rules and follow all the rules. That would be us in practice settings. He who doesn't follow the rules will likely have to give all the gold back and pay penalties and fines, and that's in an audit. He who has to give all the gold back and pay penalties and fines will likely be out of a job. Insurers' rules rule. So here's the good news already with the Medicare waivers for the DSMT and the MNT benefit, but we're focusing today on DSMT, is that a lot of these insurers' rules, the Medicare rules for DSMT pre-pandemic, pre-COVID, they have relaxed many of those rules. Medicare has made it much easier for us to furnish telehealth in a telehealth modality without a lot of the very restrictive rules that we have for in-person. So this poem doesn't apply 100%, but it kind of gets our minds in the right direction. The waivers are considered now, I guess, the rules, but they're so lightened up, it's like we have this fresh air coming into our practice setting. So, you know, the Medicare reimbursement rate maze, we all know that. And a lot of times right now, especially, I always start my reimbursement talks, and I did not do this for this one, I do this for all of them, that the Medicare reimbursement rules, even pre-COVID and post-COVID or during COVID, are all about the C's. They're copious and convoluted and confusing and complicated and complex and constantly changing. When I got this picture, it was really funny. When I created this slide years and years and years ago, I asked my children, which were teenagers at the time, find me a picture online that looks crazy and confusing, and this is what they came up with. So this constantly changing scenario, and again, just last night, I got another little small change. How are you going to keep abreast of these changes? Well, first of all, you can sign up for what's called the Medicare Learning Network newsletter on the CMS website, which is cms.gov, and you have the URL address at the bottom of this slide. But if you just go to cms.gov and put in their search box, Medicare Learning Network, you will get access to a sign-up. Now, this newsletter, it's electronic. It comes in any email address you give them, and you do not have to be a Medicare provider to sign up for this newsletter. My son, who's a restaurant manager in Michigan, can actually sign up for this. You do not need to be a provider. And this is what I use in my inbox in order to keep up with the changes, because I have to teach them all the time. It's a really great newsletter. The other ways you can keep up is by going to these 3 websites that are inputting the changes as rapidly as they can. The Association of Diabetes Care and Education Specialists, the Academy of Nutrition and Dietetics, because they're involved, of course, with medical nutrition therapy. And these waivers that we're going to talk about today for DSMT also apply to MNT, medical nutrition therapy. And then the last, of course, is the CMS website. That URL will take you directly to the telehealth waiver pages. But again, if you lose these URLs, just go to the basic websites and the home page will guide you to where those telehealth pages are and the COVID pages are. So first let me talk about the difference between MNT and DSMT, because this is not about MNT today. This is about DSMT. But I'm still getting a lot of emails and questions, even during COVID, about the difference. And again, I'm not going to read word for word, but just a very simple explanation. When we talk about medical nutrition therapy, it's a very personalized meal plan, nutrition therapy meal plan to control the ABCs of diabetes, A1C, blood pressure, and cholesterol. Very personalized. And so self-monitoring of blood glucose, exercise, medication plans, that all gets tied into the meal plan. One begets the other and vice versa, taking into account patients' lifestyle and preferences and that sort of thing. We do longer-term follow-up to see if their eating habits are affecting their labs, if they're improving, and then we make changes as needed. DSMT focuses on general training of key self-care behaviors to control the same ABCs, but primarily in a group format. And realistically, it's about, in DSMT, it's about teaching patients about the basic concepts of self-care, the evidence-based behaviors, but in the mode of one size fits all. We don't really individualize the behaviors in DSMT. So if I was teaching all of you in a group class right now, and I was teaching about in DSMT about fiber, I would say generally, you know, fiber is your friend. This is what it does. But if someone says, well, how much fiber should I get, or how much protein should I get? I'll say, well, that's going to be calculated for you individually in your meal plan and the MNT benefit. So then when we talk about nutrition and the DSMT benefit, again, how do we approach that? Because it's not personalized, it's not individualized. Again, it's one size fits all. We all have to reduce our carbohydrates, control them, I should say. And somebody raises their hand and says, well, how many should I get per meal? Well, that'll be determined by the dietitian in the MNT benefit. So that's just a very basic, simple explanation. And the two are complementary. The patient should really have both to maximize their outcomes. So now let's go directly into the waivers for Medicare DSMT telehealth. Now, once again, this is strictly about Medicare. This is not about commercial payers or your state Medicaid program. This is strictly Medicare, and it's strictly the telehealth modality for doing DSMT. So the way I set up these slides, on the left, you have the original Medicare rules for the subject matter in the subject line, and then on the right, you have the COVID-19 waivers related to that subject right at the top of the slide. So when we talk about telehealth DSMT, on the left, it's HIPAA compliant, interactive audio and video telecommunication in real time. So like today, this is audio, you can hear me, but I can't hear you, okay? I can't hear you at all, so this wouldn't work. You don't see me, and I don't see you. So this is not considered, by definition, the kind of telehealth modality for DSMT. And for COVID, I'm just going to say COVID, that it's the same now under COVID. It has to be audio and visual in real-time communication. And again, just as a reminder, drop your questions in the chat box, and roughly every 15 or so minutes, give or take, we'll open it up and the organizers will read me the questions, and I'll do my best to answer as many as I can within the time frame. And just as a reminder, if we don't get to all the questions, even at the end, we'll save time at the end, the organizers are going to coalesce the questions and forward them to me for answering post-webinar, and then get those answers posted in a very timely fashion. So let's talk about now the DSMT referral. Okay, original. We do still have to have a referral, and you have to have one for the initial benefit, and you have to have one separately then for the subsequent years for the DSMT. I don't like to say follow-up DSMT because that could mean, I think we have to stay away from that word. This is just my opinion now. Follow-up could mean like the next week. I see Martha Stewart, our patient, on Monday, and I follow up with her next Monday for another visit. So I like to say subsequent year. And there are several items that have to be documented on the referral. So what I did for you, part of what you're going to have access to is not only the slide deck after the webinar, so just bear that in mind. If you're taking notes fast and furious, you are going to get the slide deck. And I also gave you my own referral that I created that I tried to make as Medicare compliant as I can for DSMT, MNT, and the Medicare obesity benefit is on there under services to be performed, and remote patient monitoring and CGM. So it's a Word document. It's totally modifiable by you. So I hope it helps. And over on the left here on this slide, there are 3 conditions that exist for doing all 10 initial hours in the first episode of care to be furnished individually. This is pre-COVID. There's 3 conditions. So over on the right here on COVID, this is the same. The referral requirements are the same for the COVID pandemic. But what Medicare did is they added a new condition to allow all 10 hours to be furnished individually in the initial episode of care. There used to be 3 conditions to do all 10 hours individually, and now they added a 4th, and that 4th one is the COVID-19 emergency. That is the new condition that allows all 10 initial hours to be furnished individually. But the provider, I'm just going to say Dr. Miller at this point, and Martha Stewart is our patient. You know, I always use Martha. It's just funny because from all the commiserating I do with colleagues, you know, she went to prison and resurrected her career. How good is that? Got to admire that woman. That's why I always use her. You either love her or hate her. I think she's marvelous. So, so let's say that Dr. Miller is giving you a new referral for Martha, and if you have on your referral the COVID-19 emergency under your special conditions, that will then allow you to do all 10 hours individually, and he checks off COVID emergency, you can do then all 10 hours individually. So that's really, really good. If you have an existing referral, initial referral right now for Tom Cruise, and Dr. Miller checked off group, then you'll have to get another referral with one of these conditions for all individual, so you have that in your documentation. And I'll show you a snippet in a minute of my referral form where I inputted the COVID emergency to get that special condition on the referral. Now, the other 3 conditions that have existed pre-pandemic to get all 10 hours individually is there's no group class scheduled within 2 months of the referral date. And now what we're saying is that because of social distancing, because of those mandates by the federal government, you may not have scheduled your group class out. You didn't schedule them because we're following social distancing. So that is one of the conditions we can apply right now because of social distancing. You did not schedule the group classes in order to do it all individually. The other condition was ordering an order on the referral. Again, this is for the initial DSMT, just 3 words, additional insulin training. Those are not my words, that's Medicare words. So you'll see I have that on my referral for Dr. Miller to check off. And that the third condition are these special needs. And again, the COVID-19 emergency is what they added now as a special need. But the existing special needs that limits group learning is hearing, vision, language, cognitive, and non-ambulatory. So I'm going to show you a little snippet of my referral. And again, you're getting this as a Word document, and it is Word. It's not PDF, so this is all modifiable by you. And I know most of you are getting electronic referrals, but this at least can be maybe an example of how your electronic referrals can be done, because you really, even though they're electronic, we still have to be careful that we make them Medicare compliant. We don't get a pass because they're electronic. So that's a really important point. So you can see here, ladies and gentlemen, what I did is I added in the red box the COVID-19 emergency period for Dr. Miller to check off. And you can see to the right of that, the existing conditions that I had on there all the time was vision, non-ambulatory, physical disability, hearing, cognitive. So I hope this helps. I really do, because, you know, we're all in this together. We're all in this together, and that's why I'm thrilled to be giving this webinar to you today. So this is the middle part of my referral form for the Medicare lab eligibility. None of that has changed with the pandemic. None of that has changed. We still need a lab documentation to prove that the patient, Martha and Tom, really do have type 1 or type 2 diabetes. And there's no distinguishing on the labs between type 1 and type 2. I'll answer questions on this later on if you have questions, but I don't want to get too much into the weeds on this because I really want to focus on the waivers. The bottom part of my referral form are the opportunity, again, for Dr. Miller to check off a diagnosis, because we do need a diagnosis on the referral. And you don't see it on here because this is just a snippet, but right above this it says that Medicare strongly prefers 5-character ICD-10 diagnosis codes. and then little instructions prompting Dr. Miller to give us a 5-digit if he can. And that's why you see some blank rows for him to give us the 5-digit. Okay, let's go to the next one, specifically about the Medicare DSMT telehealth waivers. And let's talk about the virtual or telehealth platforms and technologies. And again, this information is coming from the webinars that I attended from ADCES and from the Academy of Nutrition and Dietetics. It's also coming from their websites that they're updating almost every day. And it's coming from equally from my own research online, going into cms.gov and just, oh my gosh, obsessively reading everything I could possibly read to prepare this PowerPoint. I can tell you honestly, I've been obsessed with this for like the last 2 weeks. I was talking to Brenda Jagatic from Indiana State Department of Health just last night, and I said to her, I am living, breathing, and eating this information like 24/7. I feel right now it's coming out of the pores of my skin. So, but you know, this is all good. I mean, we know that the COVID pandemic is not good news, but in terms of what Medicare has done for us to service our patients with diabetes, in my opinion, it's nothing short of a miracle, and that's the good news. So in terms of the platforms and the technologies, what I'm learning and what I've been told is that these non-public facing remote communication platforms is what we have to be doing. The public facing platforms means that the platforms are open to the public. The information, the words are not encrypted when they go through cyberspace. They're real words in English. Anyone can jump into the platform at any time. And remember, when we're with a patient, we're exchanging what's called protected health information, PHI. And so we want to try to really focus on the non-public facing platforms, okay? So over here on the left, on original Medicare rules, because remember, before the pandemic, Medicare is paying and has paid for Medicare DSMT telehealth. They have. This has been a standard service for a long time, but they've loosened up the rules around that, and that's always what's on the right of these slides. So originally, Medicare said if these platforms are public-facing and they do not have audio and visual, they're public-facing and they do not have audio and visual, you cannot use them, So that includes telephone calls and text messages. Now, over on the right, we're still excluding, again, we're trying to exclude the public-facing platforms, okay? But here's the thing. In the waivers, Medicare has said that in an audit, they will not, and I'm paraphrasing here, they will not hold you to the fire if you have violated any of these HIPAA patient health information privacy laws with your platform. They will not hold you to the fire and burn you. They're relaxing that, and their terms are if you've shown good faith to get the best available platform to service your patients, even though it's not 100% HIPAA compliant, they will not cite you in an audit during the pandemic if you show good faith attempt to get the best platform appropriate for your practice setting and your patients. So that's really good news. There's been all kinds of chatter on the right here going back and forth the last couple of days, and oh gosh, I get so many emails and questions and text messages and phone calls to answer these questions, and I do my best. So phone calls right now, phone calls only to service Martha, our patient, is not allowed as of right now. It has to be audio and visual communication in real time. There are some CPT procedure codes, they're at the bottom on the right, that phone calls are allowed during the waivers, but they're not for us. They're for physicians and qualified non-physician practitioners, and that's the term for NPs, PAs, and CNSs that Medicare gives, qualified non-physician practitioners. So you've probably heard and read about phone only, but not for the DSMT or even the MNT benefit. Okay, so again, on the left, we have more of the approved non-public facing audio and visual platforms in real time. and this has always existed pre-pandemic. And then again, on the right, other approved non-public facing platforms. And these platforms actually came from the 2 webinars from the Academy of Nutrition and the Association of Diabetes Care and Education Specialists. And then one more thing, again, as I mentioned before on the right, that some of these telehealth platforms and technologies may not fully comply with HIPAA, but CMS and the Office of Civil Rights has published statements that says they will not impose penalties for noncompliance with HIPAA rules if you show a good faith attempt to get the right platform that is as HIPAA compliant as possible within the confines and restrictions and culture of your practice setting. Now, all of these waivers and the DSMT telehealth, this applies to all of our patients, not just the ones who have picked up the virus, okay, because there's been some chatter about that too, that these waivers will only pertain to a beneficiary with diabetes who got the virus. That is not true. That's not true at all. So that's really good news also. Okay, so let's now talk about, again, we say here that we have to implement reasonable HIPAA safeguards. And at the bottom here on the right, so that the patient is getting the most out of the telehealth visit, certain things maybe we don't think about is to lower our voices, because sometimes our voices can come through loud and strong and it can be disrupting to the patient. Not using speaker phones, and recommending that the patient is in a reasonable distance from others when discussing PHI, personal health information. So, you know, if the patient's in his own dining room, and again, the beneficiary can now be, the Medicare beneficiary can be in their own home. So that, as we haven't gotten to that yet, but that is a location now where the beneficiary can be. And so if he's in his dining room or she's in her dining room and she's got cousins and, you know, nephews and her husband with her and everyone is hearing this protected health information, that is her right. That's her right to do that. She owns her own health information. But you just want to maybe mention that to her to get someplace more private. So this is to lighten up the mode a little bit. Help me to always give 100% at work. What's today? Friday, 5%, you're getting 100% for sure. I want to give all the credit here on this photograph to the wonderful baby photographer, Ann Geddes. If you've ever seen her work, there's a couple more pictures coming up. Okay, we're going to go through a couple more slides, and then we're going to take time for questions. Okay, the idea now at the top of new versus established patient. New versus established. Okay, now, during COVID, the original waiver rule, again, they're changing the rules. Medicare, CMS is changing the rules literally every day, and that is not even an exaggeration. The original set of rules said this would only pertain, these waivers would only pertain to established patients. Well, the Association of Diabetes Care and Education Specialists and the Academy of Nutrition kind of went crazy with that, because newly diagnosed patients who need DSMT should get it, you know, and so why can't we address new patients during the waivers? It seemed contradictory to good medical care. And so the two associations really went to bat for all of us, and they have been in communication with CMS on a daily basis also. You know, they have an inroad, you know, they have a direct line into CMS because of what they do. So CMS did relent, and now the adjustment is established patients are now included in these waivers. They are included in these waivers. Okay, one more topic, and then we'll take questions. Educator documentation requirements. Do we have to do anything less or anything more because of or in the COVID period? Do we have to do anything more or anything less? Well, the answer is yes and no. Sounds kind of crazy, doesn't it? Okay, this is what I mean. We have to document everything we did before. Everything we did before. That's all the same. And just remember that the codes we use for Medicare, the codes that Medicare wants us to use, and again, the procedure codes could be different for Blue Cross or Aetna or Cigna in your own state. And again, Blue Cross in Illinois may have different codes for diabetes education, Blue Cross in Indiana may have different codes. Blue Cross in California may have different codes. So with your commercial payers, you have to find out what codes they want. But with Medicare, they want the G codes, our beloved G codes. G0108 for individual and G0109 for group. Now, so these are time-based codes. Anytime you have time-based codes, you always have to document your start time and your end time, and that's face-to-face with the patient. So if you start with Martha, and this is still going to be true virtual, telehealth. So you start the telehealth visit with Martha at 10 a.m. Central, and that's when you have her audio and visual on the platform. 10 a.m. you're starting, and then you're done at 10:30, and then she signs off. So you've got 10 o'clock was start time, 10:30 was end time. Now, let's say that you sign on at 9:45 in order to get ready for the telehealth visit. That time does not count because Martha is not with you face-to-face at this point. You're just getting ready. That's pre-visit time. That does not play into the time you can count for billing purposes. The time you count for billing purposes is when you're face-to-face with the patient in the visit, whether it's virtual or in person, okay? Now, what's changed with COVID? My suggestion, now again, CMS has not specifically said this. This is my impression or my interpretation, because I'm also an endocrinology coder, about good documentation. If it were me, and I did work in this field for 18 years in a hospital outpatient setting, and if I still was, I would be also documenting the platform I used, like Facebook Messenger or DoxyMe or WhatsApp. I would document the platform for sure, okay? I would document the location of the beneficiary during the telehealth visit, that the beneficiary was at home, the beneficiary was in a library, on a computer, just so that my documentation was thoroughly complete. Okay, now before I move on, as promised, I'll have the organizers read me some of your questions if there's any in the chat box.
Okay, Marianne, a couple of questions. Melanie had asked, and I'm not sure if you're covering this in your slide deck, is as a registered dietitian, do you need your NPI number to charge for DSMT MNT?
Okay, a registered dietitian who is a Medicare Part B provider, and in the house, in the club, Medicare active Medicare Part B provider, can bill Medicare Part B directly for Medicare MNT and bill Medicare directly for DSMT. That is true. But an NPI number doesn't make you a Medicare provider. You need an NPI number in order to fill out the CMS enrollment form to become a Medicare provider. And then you get what's a PTAN number, a provider transaction access number, and then you are a Medicare provider. So yes, if you're an RD and you're a Medicare provider and you're billing directly, like you're in private practice, you do use your NPI number as the rendering provider, and then you use your business, your organizational, your private practice entity NPI number as the billing provider, because you should be billing under your private practice, okay, for all kinds of financial protections and malpractice protections. So I hope that answers the question.
Okay, and then there was, I think it was Jonas asked a question about federally qualified health centers and rural health centers. I believe you're going to be addressing those in your slide deck up ahead.
Yes, and I'll tell you just really quick, 15 seconds. Yes, in the waivers, Medicare has now said, and to simplify this and make it easier for us and to increase access to all this telehealth, which is wonderful, FQHCs and RHCs, but this is coming up in the deck, are now allowed to do telehealth. They are now allowed to be distance sites in order to do the telehealth, and that is coming up on some future slides.
Okay, and then Tara has a question that if you mark COVID emergency, but once the class date arrives and a group class is okay per social distancing, will we be penalized for doing a group class at that point? Does it warrant a new order?
in my opinion, again, because when I always say my opinion, that means that, just so you understand, that I have not read any specific CMS words about that or any Medicare words about that. But from what I know, what Medicare is doing, and from my background, no, you will not be penalized, because they're easing up their original pre-pandemic rules so much. It's almost like if you had a rope that was tied in a million knots, and every day another knot is being removed from the rope, and it's making it loose and easy to manipulate and move around. So no, in my opinion, you would not be penalized.
Okay, another question, and I think this is a question that pertains, I think your answer will be you follow the same rules whether you're doing it telehealth or in person. But the question from Brenda is, if a patient has a hearing impairment, can a family member or other support be on the visit?
Oh, absolutely. And even pre-pandemic, the beneficiaries, and when I say beneficiary, that's specifically meaning a Medicare patient. That's the term that's used to signify Medicare. Beneficiaries have always been allowed to bring caregivers, family members, anyone else who's involved in their care or want to be involved in their care to the visit, whether it's, again, in person or telehealth. You know, again, but just in my opinion, you know, telling the beneficiary ahead of time, you know, we are going to be exchanging, as you know, personal health information, and you're welcome to bring caregivers and family members as long as it's okay with you that they hear your personal health information.
Okay, great. Another question from Mariana is, and it's a question I think that there's a lot of nurses out there with this question, can a nurse who's a certified diabetes care and education specialist charge for telehealth?
Okay, there's two answers to that question, and we have slides coming up. First of all, nurses, RNs, not NPs, but RNs, cannot directly bill, cannot directly charge Medicare because their Medicare does not allow them to be in-network Medicare Part B providers. So they cannot bill. And when I get that question about billing, I have to take a step back and say RNs cannot be Medicare providers, they cannot bill. I think what's embedded in that question is, can RNs furnish Medicare DSMT telehealth? We have a slide coming up, but this is the answer. The answer is no. The original pre-pandemic DSMT rules for telehealth is that nurses are not on the short list of provider types, healthcare professional types who can render DSMT telehealth. And that has not changed during the pandemic. And this is very much, oh my God, this pains me to say this. This is so heartbreaking for all of us. I get tears in my eyes just thinking about it. And again, ADCES and the Academy of Nutrition is working so hard to change this as we speak, Okay, but here's the good news I got last night. I just got this last night from the the Association of Diabetes Care and Education Specialists. I actually emailed this question to their Chief Science Officer and VP about if an RN provides this telehealth, because this came out from ADCES yesterday. If an RN furnishes it, and we know that Medicare is not going to pay for that, it's not allowed, then you do not submit a claim to Medicare for the RN telehealth visit, and that you can give it away for free. I just got this from ADCES this morning when I asked them that question last night on an email. So again, I'm going to repeat this because this is not in the deck. If you have an accredited ADCES accredited DSMT program or an ADA recognized program, which is still required to bill Medicare, and an RN is giving the telehealth visit during the pandemic, okay, the institution, the practice setting, can choose to do it then for free and not charge the beneficiary at all. The practice setting can also choose to give the beneficiary an ABN, an advanced beneficiary notice, and that's a Medicare form that you get from the CMS website, and it's a printed form that says this benefit you're about to receive cannot be billed to Medicare, okay? And there, instead of charging you out of pocket, that now because of the pandemic, this will be free. Or if you're going to charge them out of pocket, then you really should give them the ABN. Okay, because that's what the ABN is for, to let them know that you cannot bill Medicare, and you have to list the reason why, because an RN is delivering it, and we will be charging you this fee. Do you still want the benefit? If they say yes, then you can charge them out of pocket. But in the pandemic, if the RN is furnishing it, you can give it away free, and you do not have to give them the ABN, if that's your practice settings policy, if they agree with that.
Okay, Marianne, just one other question I'm going to discuss with you, and then I'm going to let you get back to your slide deck. And it's interesting, someone had asked if the provider location can be remote as well, and I know you will be covering that in fact, diabetes educators can be delivering services from their home, but you're going to be discussing that in more detail a few more slides.
Yes, absolutely, I will, Brenda. Yep, because Brenda, I just have to tell everybody, ladies and gentlemen, Brenda has already seen my slide deck. She's got a little inside track on what's coming. So that's great, Brenda. I will be covering it where the educator can work from their home, like I'm doing right now on my dining room table, and the practice setting can still bill as if it was done in person at the practice setting. And that's coming up.
Yeah, I'll let you get back to your slides. Thank you.
Okay, thank you, Brenda. I hope that was helpful to everybody. So keep putting your questions in. This is great. And I appreciate all of you being patient with this and being on this webinar. Just wish I could be with you in person. It would be so much better. So in terms of reimbursement, nothing has changed pre and during the waivers. So on the left, we have the national unadjusted rates. And what do I mean by that? These rates that you're seeing on the left are not geographically adjusted. And what does that mean? For many of the Medicare, I think for all of the Medicare benefits in the Medicare system, they geographically adjust the payment rates based on the region. So, and how do those rates get adjusted? It has to do with cost of living in a certain area. And I know a couple of years ago, San Francisco, California had the highest cost of living than any city in the United States. So the reimbursement rates are the highest a couple years ago in San Francisco. Now in comparison, and this is kind of a joke, if you live in Timbuktu, Alaska, I don't even know if there is a Timbuktu, but I would assume that the cost of living in nowhere in Alaska would probably be very low, and so the rates geographically adjusted would be lower. Now, for DSMT with the G codes, Medicare does not adjust the rates for facility and non-facility. Now, this is unlike MNT. With MNT, again, we have geographically adjusted rates, but those rates are also then adjusted for facility and non-facility in the MNT benefit. But for DSMT, the rates do not change facility to non-facility. And what do we mean by facility? That means hospital. So this is all Medicare and reimbursement language. It's actually reimbursement language. It's like going to France and having to speak French to communicate. When you're in the circle of reimbursement, we have our own language that we speak, and sometimes it's very, very confusing. So when you hear facility, we mean hospital. So you can see the rates there. Now, here's the good news. The rates are the same. You're, in COVID, when you do it virtually, telehealth, remember we're talking about telehealth, the rates are going to be the same. But on the right, you can see here that Medicare says you, or your practice setting, you can reduce or waive the cost sharing to Martha and Tom, the beneficiaries. Because with the DSMT benefit, pre-COVID, the beneficiary had to pay 20% of the geographically adjusted rate, okay, for the claim. You can waive that. You can completely dismiss it and have the beneficiary not pay at all that 20% copayment. Or you can reduce the 20% copayment and say we only want from you 10% during COVID, or we only want from you 5%. And again, that's a financial decision that your practice setting will make. And if you share this deck with your administrators and finance people so they understand what the current waivers are, I think that would be a really, really good idea. Okay. And then again, we're going to stop in about 7 or 8 more minutes and I'll take more questions. So let's now talk about individual versus group visits. Again, this is about telehealth specifically. The original Medicare rules was that when you do the initial benefit, you have 9 hours that has to be in group, and you get 1 hour individually in that initial benefit, okay? And that was the same when you do telehealth. This is pre-COVID now. 9 hours in group, 1 hour individually, and the only way to do all 10 hours individually if you meet one of 3 special conditions, like additional insulin training, a condition that limits group learning, or you have no group class scheduled within 2 months of the referral. And now we have a 4th condition, and that's the COVID emergency, to do all 10 hours individually, okay? In telehealth, on the left, originally, it said you're doing a telehealth, 1 hour of the initial 10, and 1 hour of the subsequent year, 2 hours, had to be in person. This is telehealth now, had to be in person for training on injectable medication. So now what has happened on the right with the waivers? Again, all 10 hours can be individual if Dr. Miller or nurse practitioner Barbara Smith says on the referral, documents on your initial DSMT referral, that one of those 4 conditions have been met that allows all 10 hours to be individual. And remember, the COVID-19 is the new 4th condition to do all 10 hours individually. And that helps a lot when you're talking about telehealth, because you can do group DSMT telehealth, but it's logistically more difficult, because if let's say you have 5 Medicare bennies in your group telehealth class, and all 5 bennies are in their own separate homes, and they all have to get on the telehealth platform at the same time on their own computers or smartphones at 9 o'clock in the morning in 5 different homes on 5 different devices. Logistically, it could be difficult. So only dealing with one patient at a time for the visit, where only one patient in their home gets on the platform, is logistically easier. So that's why this is really, really good news. The last bullet point on the right, that in-person requirement for injectable medication has gone away. That's not required. So you can now do the injectable medication training on the telehealth platform as part of the COVID-19 waivers, and that is really, really good news. Okay, let's talk about procedure code modifiers. Okay, on the left, original. Medicare had originally said years ago that when you do DSMT telehealth, when you submit the claim, this is pre-COVID, that you had to use the GT modifier, attach that to the procedure code, G0108 GT, G0109 GT. Okay, now about 2 years ago, this is pre-COVID, they said, no, and this is why you have to get that Medicare Learning Network newsletter, because this is where you're going to keep up with the changes. This is really important. So a couple years ago, they said, no, we want to simplify billing for our providers, and we're going to remove that GT modifier requirement for DSMT telehealth billing. But critical access hospitals method 2 still have to use the GT modifier and on the procedure code. And that GT modifier is defined as via interactive audio and video telecommunications system. It's a mouthful. Now, why they made an exception for critical access hospitals method 2, they still have to use the GT modifier, I have no clue. That's why I said in one of my slides at the beginning, that the Medicare rules are just confusing and complex and convoluted. We don't know why they do what they do sometimes. But you know what? I'm not going to denigrate Medicare. Thank God they're there. I love the healthcare system. And boy, what would we do without it, right? Okay, so let's move now over to the right, COVID waivers. We still have that GT modifier required for critical access hospitals. That hasn't changed. But what if your practice setting bills on a 1500 professional claim form. And what if they bill on a hospital UB04 claim form? Those are two different claim forms that are used in two different types of medical entities. Remember we talked about facility, and that's hospital. Hospitals always, I would say 99% of the time, use a UB04 claim form to bill Medicare. For their inpatients and their outpatients. They can use a 1500, and sometimes they do for certain services to bill Medicare, but the vast majority of the time they use a UB04. It stands for Universal Billing. Okay. All the other type of practice settings that are not hospital, physician practice group, independent clinic, private practice of an RD, they have to use the 1500 professional claim form. And you can look these up on Google or Yahoo or Bing. You can actually call them up and visualize them and look at the data fields, okay? So what the waivers are telling us right now is that they want us, this is the waivers for DSMT Telehealth, they want us to use modifier 95 during the waiver period when you're billing Medicare for DSMT Telehealth. Okay, and that's on either claim. You attach the modifier 95 to the procedure code G0108 or G0109. And that modifier 95, you can see what it says here, telemedicine service in real-time interactive audio and video telecommunication system. Okay, so we got that squared away. Boy, every time I go through one of these, I'm like, that's another big hurdle. I picture in my mind another big knot in this rope being loosened up. Don't you feel that way? If you agree with me, you may want to jump in the chat box and say, I agree, Mary Ann, we're loosening up these knots and we're making this so much easier, you know, and then we could take that rope home and do something else with it. Okay, so now, again, this next subject matter, billing on a professional 1500, again, all this confusion that's been buzzing around. You know, it's funny. If I had a nickel for every question, every phone call I've taken, and every email I've answered in this last 3 weeks, because I'm a shut-in, I'm in Illinois, I can't leave my home, I would be a millionaire right now. You know, I'd be ordering a case of Dom Perignon. But anyway, here we go. The hospital billing. Billing on a professional 1500. Again, originally, for Medicare DSMT Telehealth, on the 1500, that's non-hospital, you had to report place of service code 02. Now, that's not a procedure code modifier. That's a place of service code 02, telehealth visit. All right, telehealth visit. Now, let's go over here to the waivers, okay? You can still report place of service code 02. But you don't have to, and this is just as of last night, believe it or not, okay, just as, and this deck was submitted on Wednesday, so this was last night, Thursday. Medicare came out last night and said you can still use place of service code 02 on the 1500 professional claim form when you're billing DSMT telehealth or any of these other telehealth services. This is not just for DSMT. It's still okay to use it on the 1500 claim form. But your practice setting can also use the place of service code that was for your in-person, face-to-face DSMT visit. So if you're working in a physician office, that place of service code is 11. And even though you're doing it telehealth virtually, you can still use 11 because that's what you were always using pre-COVID. And you can also use, if you want, instead, the place of service code 02 for a telehealth visit. The reason they're, as of last night, they're saying go ahead and use your original place of service code that you use all the time pre-COVID, because again, they're trying to lighten up all these rules, take away a lot of these rules to make it easier for all of us to do this logistically and service our patients. So that is really, really good news. And on that 1500 claim form that non-hospitals use, there is a data field for place of service code. You do have to put a code in there. because when your claim then is electronically submitted and it goes through the filters at your MAC, your Medicare Administrative Contractor, when it goes through those electronic filters, every data field that's required for completion, if a code is in there that's not in the Medicare system because it was erroneously entered, your claim will be kicked out. If that data field is blank, your claim will be kicked out. So that's an important thing to know about these filters. Now, what about billing hospitals on that UB04 claim form? Okay, this is all kind of brand new in the last week. Now, original Medicare rules. What they asked you to do on the hospital claim form was to bill revenue code. This is pre-pandemic. UB04 claim forms have a data field or a box for a revenue code. The 1500 professional claim form does not have a revenue code data field. They don't use revenue codes. Only hospitals use them on the UB04. So pre-pandemic, we were using 780 as the revenue code when we did Telehealth DSMT. And that revenue code for hospital billing is telemedicine general. And remember, on the UB04, there's been all kinds of confusion on this. There is no place of service field, so you don't enter a place of service code 02. It doesn't exist on the UB. So over here on the right, for now you're submitting claims during the COVID emergency for Telehealth DSMT. You're going to report revenue code 780 on the UB because there is a field for that, and a revenue code has to be inputted in there. Otherwise, your claim will be kicked out when it meets that particular filter. And they still want you to use, in the COVID period, the modifier 95. That's on the procedure code, the G0108 and the G0109. So I know we're throwing a lot of codes at you. There's the modifier code on the procedure code. There's the revenue code that's on a UB04. Then there's the diagnosis code, the ICD-10 diagnosis code. So welcome to the world of reimbursement, right? I mean, I feel bad. It's easy for me to talk about it because it's one of my specialty areas, but I can understand that right now you're probably thinking, oh my gosh, Marianne, this is getting so muddy. I'm going out of my mind. So just take a breath and just try to go, and you'll have this deck, so that's the really, really good news. So let's stop here. And Brenda, do we have any questions?
Okay, Marianne, yes, we do have some questions. And first, Sheila had asked, and I'll just, I'm sure other people may have had a question about this. With regard to our webinar, it is being recorded and it will be available on the Upper Midwest Telehealth Resource Center website, where you went to register for this webinar. In addition, the slides will be available. Marianne's slide deck will also be available, as well as any questions that we did not get a chance to answer. Marianne will answer those questions, and then that summary will be also placed on the website. Now, Tara had a question about Medicaid, and I'm just going to just answer this really briefly for her, in that your regional telehealth resource center is going to be the best source of information to understand your state's Medicaid rules on telehealth, any changes that have been made, and also they may also be able to provide you with information on what the coverage is for private payers. And Marianne, I do have one question for you from Rebecca.
Okay.
Do we have to be in the same state as patients, since we don't have state registration for diabetes educator designation?
Read me that question one more time, a little slower.
Okay, sorry about that. I do talk too fast.
No, you're fine.
Okay, this is from Rebecca,
Mm-hmm.
and she has asked, do we have to be in the same state as patients, since we don't have state registration for our diabetes education designation?
Okay. I think I'm mute. Oh, here we go. I'm muted. Thank you, Autumn. Autumn is controlling all the technology. Autumn, you don't have to mute me when I hear those questions. I'm fine. We want to give Autumn a big shout out, because without her, Thank you, Autumn. This technology would not be being used so wonderfully if Autumn is controlling this. Thank you, Autumn. Okay, I've got a slide coming up. I think that question refers to licensure credentialing in the state where the educator is sitting, and is that educator then also licensed or certified in the state where the beneficiary is sitting? And I think that, and Rebecca, please enter into the chat box if I'm interpreting this question incorrectly, but I do have a slide coming up if that's the nature of your question. In the pre-COVID original rules for DSMT telehealth, the original telehealth rules say that the educator, the healthcare professional, has to be licensed or credentialed, whatever your state has for your profession, in the state where you're sitting and in the state where the beneficiary is sitting. So like Illinois and Indiana butt up against one another, right? And Brenda, our coordinator here, is in Michigan, okay? And so, yes, it's conceivable where I'm the educator, I'm in Illinois, and my beneficiary is in Indiana or Michigan. The waivers, the COVID waivers say they're going to waive that licensure certification in both individual states is waived. You don't have to have it in both states. Okay, that's the COVID waiver. But, and here is the huge but, and I heard this on webinars from ADCES and the Academy of Nutrition. Your own state has regulations about medical services. The Department of Professional Regulation in your own state has rules and laws for all medical professionals for in-person medicine delivery and telehealth delivery. So if you're an RN, an RD, a social worker, a psychologist, and you want to do telehealth in your profession and bill Medicare, that licensure certification in both states is waived. But in your state, is it waived? Is your state still going to hold to that with licensure and certification in both states? So you really have to check with your own state's licensure board for the telehealth modality for your own profession.
Thank you, Marianne. And Rebecca said that you did correctly interpret her question. And I'm just going to follow up your answer with the fact that last week, I attended the National Consortium of Telehealth Resource Centers had a webinar. They had something like 5,000 people registered. And in that webinar, the thing they stressed is people have to realize exactly what you just said, that yes, there are medical waivers so that's federal law, but people have to be aware of the laws within their own state. And so another resource that can help, I'm getting a bit of feedback. Another resource that can help is reaching out to your regional telehealth resource center. And if you just Google telehealthresourcecenter.org, you will be able to find it. But we will also provide information for that as well in our follow-up in terms of how you can identify who is your regional telehealth resource center. Thank you, Marianne. I'll let you get back to your slide deck.
Okay, perfect. You're asking great questions, and Rebecca, thank you for responding on the chat. I'm giving you a virtual hug. I'm giving all of you a virtual hug, right? That's what we have to do these days since we can't be in person. Okay, what about originating sites and distant sites? You've probably heard those terms before. This is like, a foreign language. But again, related to telehealth DSMT. In pre-COVID, the originating site is where the beneficiary is actually sitting during the telehealth visit. This is actually sitting there. And only certain medical entities can be originating sites where the beneficiary is actually sitting down and listening to the telehealth visit. This is pre-COVID. So we've got all of those listed here on the left, and there's still more on the next slide, okay? But let's go over to the COVID waivers. First of all, on the left, original. These sites where the beneficiary is sitting, the originating site, they had to be in a rural area, what they call a non-metropolitan statistical area, non-metro statistical area, or rural. In COVID waivers, those rural site limitations are removed. They're gone. They're gone. So that's really good. And look at the bottom here now on the right. What they added as an originating site was the beneficiary's home. That was never allowed pre-COVID. So now the beneficiary can be at home and that home does not have to be in a rural area. It could be in downtown Manhattan or downtown Detroit or downtown Chicago, which is metro, okay? And if your beneficiary is going to a physical location, which they're probably not because of the shut-in requirement, that location, that medical entity, does not have to be, again, in a rural area because that rural restriction or requirement has been waived. So here on the next slide, this is also under the original telehealth DSMT. These are more of the originating sites that have been approved pre-COVID, okay? And again, it says here on the left, original, that these sites had to be located in a health professional shortage area, a lot of fancy words for meaning a rural area. And again, in COVID, that rural area restriction has been waived. Okay, another wonderful picture from Ann Geddes. Just love this lady. And I wish I had a baby girl. I've told Brenda, I don't know how many times, she has granddaughters. I'm so jealous. I have 2 rugrat sons. My mother taught me about the science of osmosis. Shut your mouth and eat your supper. Isn't that too funny? Again, credit to Ann Geddes. Okay, distance sites. Distance sites is where the educator is sitting. Okay, that would be all of us. And originally, with the original rules, if there's certain distance sites that are excluded from the telehealth DSMT benefit, excluded. Pharmacies, beneficiaries' home, rural health clinics, federally qualified health clinics, independent renal dialysis facilities, meaning a renal dialysis facility not connected to a hospital. And included was everything else, hospitals, clinics, physician offices, even an RD private practice. Now, in the waiver period, it's the same in terms of excluded, but what they removed from the excluded, and now we can use rural health clinics and federally qualified health clinics can now be distance sites, meaning in simple language, ladies and gentlemen, they can do telehealth now. An educator sitting in an FQHC or an RHC can furnish DSMT telehealth and also MNT telehealth to their beneficiary members, so to speak, that's coming to their clinics, and they are allowed now to do that. They can now function as distant sites, and that's really, really good news. Okay, let's talk about the educator working from home. And this has been flip-flopping for the last couple of weeks. When I tell you I have lived, breathed, and ate this information for the last 2 to 3 weeks, that's not an exaggeration. I've literally been up till 3 or 4 o'clock in the morning working on this. It was funny. I have to tell you a funny story. My husband goes to bed early and gets up early. And so one time I was up till 4 a.m. working on this deck. And my husband gets up and he's looking at me in the family room. He goes, "You haven't even been to sleep yet?" I said, "No, I'm still trying to figure out these waivers." So anyway, working from home. In the original rules, the educator could not. And now with the waivers, we have another big knot being loosened up on that rope. Not just diabetes educators, but all practitioners who have been allowed to render telehealth services, they can now do it from their homes. That's really, really, really good news. So let's talk about what that means on the waivers. Medicare said originally in the waivers, remember they've been changing them every day. They originally said, in case you have this information at your practice setting, that the Medicare provider had to call Medicare, the Medicare hotline, and add home as a practice setting to the Medicare enrollment file. And then in the last week, Medicare said, and that's reflected on this slide, no, you don't have to do that, because I know you're going to have probably contradictions when you get back to your practice setting. This is brand new, hot off the press, because Medicare is trying to simplify the logistics of billing. You do not have to add home to your Medicare enrollment file. You can go ahead and furnish the DSMT from your home, and on your claim, your bill going to Medicare, you can use your regular practice location, your place of service code, your place of service code that is the same as if you did it in person at the practice location. But you can also use place of service code 02, which is telehealth, on the 1500 claim form. So now you have a choice if you're doing it from home. On the claim form, on the 1500 claim form, because on the 1500, there is a place of service data field. You can use your original practice location when you do it in person as the place of service, or you can use 02, which means you did it via telehealth. I know that's confusing. Now, what is AADE, Association of Diabetes Care and Education Specialists? What have they told us? First of all, ADCES, they're still using the term AADE for accreditation purposes because CMS has them listed as AADE, and that's going to be a long process to change that. Okay, so if your program has AADE accreditation, if you're working from home, AADE wants you to go to their online DAP dashboard, that stands for Diabetes Education Accreditation Program, and add home as one of your accreditation community sites. This is an AADE request requirement to add your home as a community site, which is free. You don't have to pay for that. If you have ADA recognition for your program, you have to go to their ERP portal, Education Recognition Program, and add home as an expansion site because they want to keep track of that themselves. Okay, beneficiary out-of-pocket payments. A couple more minutes, and then we're going to open it up to all kinds of questions. Pre-pandemic, the beneficiary had to pay 20% of the geographically adjusted rate for every visit. Now, in the waiver period, we talked before, you can waive that 20% or reduce it to 5%, 10%, 12%, or you can waive it completely. And that's your practice settings decision. Okay? State licensure. I think we already answered this, so I'm going to skip that, but you have it here in print because you are getting this deck. Okay, distance site practitioners. That's where the educator is sitting. Before the pandemic, okay, who can furnish DSMT telehealth? Very short list of who can furnish. And you can see here on the left that RNs are not on this list. During the COVID-19, they have not waived that. They have not made any changes in that. And again, ADCES is working so hard to change this for RNs. I can't even say a big enough adjective to tell you how hard they're working to change this. And as I said before, I get tears in my eyes thinking about this ridiculous rule. And I'm sorry I have to say that, but, and I can say this because it's my own protected health information. When I had breast cancer 12 years ago and I was hospitalized, stage 1, I give all the credit to the nurses that got me through that. Yeah, the doctors come and go, but it's the nurses who hold your hand, who do everything else for you. I can't say enough about them. If I had another life, I think I'd want to be a nurse. Anyway, but here's the good news, as I mentioned before, real briefly. If you are an RN during COVID and you're in a DSMT program and you're doing the DSMT, your practice setting then cannot bill Medicare because you're not allowed to do it. But according to ADCES from last night, an email I got from them this morning, you can then not charge the beneficiary at all. You cannot bill Medicare, but you can then do it free for the beneficiary. And that's what I got from ADCES this morning. Okay? All right. Now, originating sites that can claim a facility fee when you're doing it in person. Pre-pandemic, the originating site where the beneficiary is sitting, they could claim a facility fee with the Q code, the procedure code Q3010. And it's about $26 right now, and they have to report type of service 9. And that's the originating site giving up a room and buying the software where the beneficiary is sitting and listening in on the visit. Now in COVID, okay, if the beneficiary does receive the telehealth in person at an originating site, then yes, the originating site can bill that facility fee, okay? if it's in person. So that has not changed. That has not changed. And that facility fee is roughly $26.65. Okay. All right. Now, these benefits are not defined as telehealth. There's been a lot of confusion on this because if you go to Google or Yahoo or Bing, you're seeing all kinds of information about COVID waivers. But these codes right now and the services they define are not defined as telehealth, okay? And so, you know, we can't use these for DSMT. We cannot, okay? And then, again, when we talk about the COVID waivers, this is pertaining to the COVID emergency. It pertains to Medicare providers. Again, licensure in both states. You have to check with your own state whether you're allowed to do telehealth in your state and what the rules are in your own state. So that's what this slide is telling you. Okay. So the time frame, there's always confusion about when does the subsequent year or follow-up DSMT kick in? Because if you don't do the follow-up, the 2 hours we get for the follow-up, if you don't do that in the right time frame, your claim is going to be rejected. This is the example that Medicare gave us for when the follow-up time frame kicks in. I just changed the dates, but because this is confusing, it's typical Medicare, I simplified it for you right here, easy explanation. So the initial benefit, the first 12 months, the beneficiary starts the 10-hour benefit. The time clock starts ticking on the first initial DSMT visit date, August 1st. Okay, it's your first initial group or individual DSMT visit date. Okay, and the last date of those 10 hours, you furnish the 10th hour on September 9th, 2020. The follow-up benefit kicks in the very next day, September 10th, 2020 in green, the very next day. But then, after that, the follow-up is every calendar year, starting January 1. Every calendar year after that, starting January 1. So you probably want to take this slide, blow it up 20 by 20 foot, put it on the wall in your office so you're within the correct time frame period. 6 ways to determine if a beneficiary had any initial DSMT in the past. I won't go through all these. This is always a question I get. Again, if I had a nickel for every time I answered it, I'd be a billionaire. None of these ways are perfect, I can tell you that. But they're here for our use. And so at least we have something we can use, right? So that's what we have there. So my parting and warmest thoughts to you. Don't you love this animated graphic? I just love this. It's so beautiful. So my parting and warmest thoughts, be best. I know that Melania Trump coined that term, but I'm coining it. And what it means for me is better, ever stronger, together. And I got goosebumps saying that. I think this should be our own new mantra during this very trying period. I'm sleepy after all that information. I'm a cat person. I had to take him out of my dining room, else you would have been hearing him meowing. Ignore Medicare and you may find yourself up a creek without a paddle. There's just too many Medicare beneficiaries who need our help. And that's why I'm saying don't ignore Medicare. They need our help more than ever. We are lifesavers. We are lifesavers when it comes to diabetes. So increase your reimbursement now. Jump into these waivers. All it takes is a little desire and strength on your part, just like a little mouse doing that little wait. Your patients, providers, and staff will love you for it. So do your homework, be prepared, and take the plunge into the waivers. I can do this. See that little mouse with the helmet? He can get that cheese and not be knocked out. You can do this. Otherwise, you're going to wake up one morning and realize you made a significant boo-boo. I don't think the cat should be in that cage and the canary on top. Isn't that funny? Is this how you feel right now? Probably so. Okay, and now I'm going to take your final questions. Brenda? Hello?
Brenda now. Sorry about that.
That's okay. All good.
What I wanted to do before we take any more additional questions, I just had some housekeeping that I wanted to deal with. And that first is I want to thank the Upper Midwest Telehealth Resource Center, specifically Becky Saunders and Autumn Daniels, for putting these PowerPoint together and supporting us in this endeavor. I also want to thank Marianne for her professionalism, her dedication to being thorough and comprehensive in the deep dive on this subject. And what I would like to say, if you have additional questions, I'd like you, or you would like the Indiana State Department of Health to give you some support around some technical assistance around this subject, please reach out to us. And our email address for this is diabetesheart, no spaces, diabetesheart@isdh.in.gov. And I think Marjorie has just put that up on the question and answer. I would also like to say that it would be really helpful if you're interested in having some technical assistance, because it gives us information at the Indiana State Department of Health to identify what are the needs in our state in terms of technical assistance on this topic. And I would also like to say that there's a link that you can go to the Upper Midwest Telehealth Resource Center, or first of all, to get a copy of the PowerPoint slides, also for the recording of our webinar, and also we'll be posting answers to questions that have not been addressed during this webinar. I'd also like to put a plug in that next Tuesday, Becky Saunders from the Upper Midwest Telehealth Resource Center will be doing a webinar, and on that webinar she'll be discussing Indiana Medicaid telehealth coverage, as well as the newest legislation around Indiana Medicaid coverage for telehealth, and covering Indiana telehealth laws. And also she will be giving us information on coverage of telehealth resources from the private payers in Indiana. And then again, next Thursday, Tony Song from California has had a diabetes education program that's been doing it via telehealth for 8 years. So I think we can learn a lot from him, and he's also going to share with us what he's been doing recently in terms of delivering telehealth services to individuals in their home. And looks like we still have some time. So Marianne, there's a question from Kate that says, can you revisit the 10 hours of initial DSME? I always understood, or she says misunderstood, that the time frame was, for example, August 9th, 2019 to August 8th, 2020.
Okay, the time frame to furnish and bill the initial 10 hours of DSMT is 12 continuous months. It is not a calendar year. The M&T benefit is a calendar year. This is part of the confusion with Medicare. The DSMT benefit, initial episode of care, the initial 10 hours, those hours have to be furnished and claimed within a continuous 12-month period. So, and that can span 2 years, as we know. So let's say you start on June 1 of 2020, right now, June 1, 2020. That's the first date of service. That's when the clock, the 12-month clock starts kicking, is on the first date of service, not the date on the referral, the date of the first visit. So you got the referral on June 1. You did the first visit on June 10th, 2020. Now you have until June 10th, 2021 to furnish and get those claims submitted on those dates in that 12-month period. So if you go beyond that, you've only furnished 7 hours in that 12 months. And the 12 months, it comes June 10th, 2021. And there's still 2 or 3 hours left in the initial benefit. They're gone forever. They're gone. Because that 10 hours is a once-in-a-lifetime benefit.
Okay, Marianne, Aubrey asked a question I'm sure we're all hoping for. When can we expect an answer about RN and pharmacists being able to bill?
I wish I had that answer. I don't. The good news here, there's two pieces of good news, is that the ADCES, Association of Diabetes Care and Education Specialists, I can tell you because I commiserate, work with them all the time on various things as a volunteer. They are working every day to get this changed with CMS because they have a direct line into CMS because of what they do in this benefit every single day. It's making all of them nuts over there. And the good news is they're working on it. The other piece of good news is that what I got last night and this morning from ADCES is that if you're an RN doing this, telehealth, you cannot submit a claim, we know that, but you can, if your practice allows you to, you can give it away for free, okay, your DSMT visit if you're an RN doing it, or your practice setting may say, okay, let's give the Benny an ABN, an advanced beneficiary notice, and charge them a nominal amount or a small amount for this. You have a choice to do it either way.
Okay, and then Susan asks, are there any considerations to be taken if a hospital practice offers DSMT education or even MNT via telehealth and does not charge Medicare and in brackets offer as a community benefit?
Okay, right now, the pre-COVID rules have been that if a beneficiary is entitled to and eligible for a paid Medicare benefit and the practice setting decides to give it away free, this is pre-COVID, they give it away free to Medicare beneficiaries who are entitled and eligible for the benefit, but they give it away free. My understanding is that that has never been allowed because Medicare interprets that as you're trying to bribe the beneficiary with a lower paying benefit, which DSMT and MNT are. You're bribing them with a lower paying benefit by giving it away free in order to incent them to come back to your practice setting for bigger ticket items like surgery, chemotherapy, MRIs, that sort of thing. But now let's move. However, there's big buts here. Doing some community classes where it's not designed to be DSMT, it's a community event where you're going over the basics of healthy living for diabetes, that's a different story. That's a completely different story, and that could be given away free. So there's gray areas here. Now, COVID, okay, if you've got an eligible beneficiary, entitled eligible, you have a referral, a doctor's referral, okay, and you meet all these COVID waivers, you meet all the rules, you should be billing Medicare. I mean, that's one of the ethical considerations in the Medicare system. Except for this RN little peculiarity here that we just explained.
Okay, maybe we have time for just one last question by Joanna, and she states, Marianne, what about those that need direct supervision, like an RN providing MNT or DSMT? How do they do this if they're working from home?
Well, first of all, educators within a DSMT program do not need direct supervision. I mean, the DSMT benefit, and I have time for a couple more questions. I'm looking at my clock. I've got a couple minutes before the end. In the Medicare DSMT and MNT benefit, those are not incident to physician services benefits. Those are not categorized by Medicare as incident to physician services. So incident to billing for those two benefits, DSMT and MNT, is statutorily not permitted. There is no provider supervision requirement. And also, somebody supervising the RN educator or the RD educator or the RD supervising the RN educator, that doesn't come into play at all. There is no requirements for that at all. Even in COVID, pre-COVID, that doesn't exist.
Okay. There's a question, I'm not sure if you've answered this one already, from Kate about the MNT 3-hour benefit period is required to start the same day as DSME starts? Question mark.
Read that one more time.
Okay, so the MNT 3-hour benefit period, is it required to start same day as DSME starts?
No. As a matter of fact, pre-COVID, you cannot do a DSMT and an MNT benefit on the same day to the same beneficiary. One of them will not, one claim will not be paid. Cannot do both on the same day. That's a pre-COVID hard and fast rule. The other part to the answer is that if you've got, on my referral form, which you're going to get with this deck, I have MNT on there also, MNT, DSMT, the Medicare obesity benefit. And if your doctor orders both DSMT and MNT, just don't deliver it on the same day. But you can start both benefits. You can be furnishing both benefits simultaneously to Martha and Tom, but just not on the same day. So you do a DSMT visit on Monday. You can do an MNT visit on Tuesday, back to DSMT. You just got to watch your time frames and your hours, because MNT is 3 hours for the initial benefit in a calendar year. So if you don't get those 3 hours furnished and billed by December 31st, they are gone forever. But the MNT benefit also has extra hours you can get after you've exhausted the 3 with another referral and medical necessity reason. But the DSMT benefit does not authorize extra hours over and above the 10. I get that question a lot too. Can I get extra hours over 10 on the DSMT benefit? And the answer is no. On the MNT benefit, the answer is yes.
Okay. Well, Marianne, I'm looking at question and answer. I think I'm just trying to see. Okay, let me see. There's one. Tara has another question. I'm not sure if the question about RN not billing, okay, let me just read this again. So I'm not sure if the question about RN not billing, not RD billing, would be ethical. We have both educators in our program.
Well, that's a very good gray area. That is an excellent question. I'm really glad that person asked that. I'm giving another big virtual hug. So now you're right. We're getting into ethics now. Okay, you have an RN and an RD in your program. Okay, now again, CMS is not giving us. Just want to qualify this answer. CMS has not given us any specific language or guidance on that specific scenario that was just asked, but it's a very important scenario. So think about this ethically. You've got both in your program, RD and RN, and we know that RNs are not supposed to be doing it, but you'd have to give it away free if the RN does it. So should you have the RD doing it? Well, you could, from an ethical and logical and procedural way of thinking, the answer would be yes, have the RD do it, because then you could submit a claim and your practice setting will get paid. Because the last thing we want to do is not be paid for our services from a sustainability standpoint. But even from an ethical standpoint, there's another way to look at that. You're getting so many patients where you cannot have the RD do all of it. There's not enough hours in her day. And you need the RN also because you have a huge volume of patients to do this via telehealth. So that's another consideration. So every practice has to look at their own unique aspects of volume, how many hours the educators are scheduled for, how spread thin they are, who's going to do what, and giving it away free. Can you handle that right now? So all those issues have to be looked at, and it's a personal decision in every practice thing.
Okay, and it looks like Becky Saunders would like to answer this question. Go ahead, Becky.
Oh, sorry. No, I'm just marking stuff that we've answered it live. You're good.
Okay. So can we go to another question? Are we done with our time?
If you're asking Marianne, I have the time, but it's up to Becky and Autumn and the other people on the line, if anybody wants to stay.
I'm okay if we want to answer a couple more.
Okay, so I have a question from Christy, and she says diabetes prevention services were not addressed. However, I'd like to point out that a huge part of our National Diabetes Prevention Program professional staff are RNs, most of which are certified diabetes care and education specialists. And for a DPP program, we're required to get MPI to bill Medicare for DPP sessions. Why can RNs bill for Medicare for virtual sessions, but not for DSMT?
Okay, first of all, two things on that. So I'm really glad we had time for this question. This is really important. Two things. First of all, in the MDPP, the Medicare Diabetes Prevention Program, this whole thing about RNs and telehealth and RDs, RNs, that's a whole different set of rules, okay, which we didn't talk about today. So, you know, you have to look at those rules regarding the RN. And I do webinars on that, but we can't do it right now. But here's the other good news. The Association of Diabetes Care and Education Specialists just yesterday did an FAQ document on the COVID waivers, and it's on their website. They just put it up on their website last night, and I printed it out, and I'm looking at it right here on my dining room table. It's a 5-page document on Q&As, and there's a whole section on the MDPP that is explaining about the waivers right now for COVID for the MDPP, what they've loosened up and allowing you to do with the rules. So get that FAQ document that was released yesterday on the ADCES website, and the MDPP waivers are in that document.
Okay, thank you, Marianne. You just
okay.
See if there's... And looks like you're getting another hug back, virtual hug back by Tara, but I'm not sure. Let me see if I've got any more questions here. Okay, so Sheila's asking, what is the website again? So, what Marianne, you go ahead and you can explain our national website.
Well, we're talking about, okay, the Association of Diabetes Care and Education Specialists. Their website has a huge section on all of these waivers, and they're updating it every day for the DSMT benefit and the MDPP benefit, the Medicare Diabetes and Prevention Program benefit. So that website, Association of Diabetes Care and Education Specialists, you can also go to the website of the Academy of Nutrition and Dietetics, and they have, to get into their pages on COVID waivers, you have to be a member. It's the professional section. It's not in the public-facing section. But then there's the CMS website, which anybody can get into, cms.gov. And that website's a little more difficult to navigate, and the URLs for those websites are at the beginning of the slide deck. And then you could also, you know, what I don't suggest you do is just go into Google and input a question in Google, because you may get an answer that, a waiver answer that is no longer valid, because they keep changing the waivers every day. Okay, so going to one of those 3 websites that I just mentioned is your safest way to get the latest waivers that are legitimate right now.
And I see that Marjorie, from my colleague at the Indiana State Department of Health, has listed our website again for asking additional questions that we can address offline, but also it will also help, it's also a way for you to be able to let us at ISDH know if you would like some individual technical assistance for your organization regarding delivery of diabetes education services via telehealth in Indiana. And Kate, of course, has also put the link to our professional organization, www.diabeteseducator.org.
And, you know, before everybody signs off, I just want to thank everyone from the bottom of my heart. I'm giving you all big virtual hugs. You know, we're all in this together. Let's be best, better, ever stronger together, and keep sharing information. You can email me. It may be a couple days before I get back to you because I'm kind of overwhelmed with all the emails and phone calls, but that's okay. I still want you to email me. And if you could just, before you disengage, if you could just go in the chat box and let us know how helpful this was on a scale maybe of 1 to 5, with 5 being the most helpful and 1 being not helpful at all. It would kind of give us an idea of how we have to change things that we do moving forward.
And then I guess the other thing I'm going to just reinforce is we're still getting some requests about how do we get copies of the slide deck and the recording. So if you go to the Upper Midwest Telehealth Resource Center's website, which is Becky, how about you give that information, make sure I'm correct?
Sure, it's www.umtrc.org. We will actually, once we've got it posted, which will be sometime next week because we'll want to wait and get all the FAQs. We've answered just about everything, but we'll want to get all the documents there and the recording there. We will send out an email. Everybody registered for this, you put your email in, your registration. We will send out an email with the link to get this information to you.
Okay. And so, I think otherwise we will close this. And again, thank you for participants for joining our webinar. It's helping us to meet our goals of increasing access to diabetes education services via telehealth to patients with diabetes in their homes during our current pandemic. And hopefully you will join us next Tuesday when Becky does her webinar. And again, Tony Song will be doing his next Thursday. And again, if you go back to where you registered for this webinar, you'll get more information there. And again, thank you so much.
Thank you, everybody.
Thank you so much, Marianne.
Be
I
safe.
appreciate your many hours, and I definitely sympathize with you. We're here at the TRC, we're getting